Good afternoon, everyone. Thank you for joining us for today's listening session, Eliminating Hepatitis C and HIV in Indian Country, a focus on urban Indian health. We will get started in just one more minute. For those of us joining us, please, while you're waiting, take a moment to provide your name and organization in the participant chat box located in the lower right side of your screen, and our listening session will begin shortly. While we're waiting, I ask that you take a quick poll. It's actually already on the screen, and it's asking, does your UIO offer PrEP or PEP? And feel free to move the sidebar up or down to expand to see the additional responses you can select. Great, thank you so much for taking the poll. I think we'll get started. So good afternoon once again. My name is Kimberly Fowler, and I am the Director of the Technical Assistance and Research Center here at the National Council of Urban Indian Health, also known as NCUIH. Thank you for joining us today for this listening session entitled Eliminating Hepatitis C and HIV in Indian Country, a focus on urban Indian health, in partnership with the Indian Health Service. The National Council of Urban Indian Health is a membership-based nonprofit that represents the 41 urban Indian health organizations across the nation that provide essential health and social services to American Indians and Alaska Natives living in urban areas. This session is being virtually live-streamed across the nation to many of our urban Native stakeholders and partners working across Indian Country to eliminate the high prevalence of HIV and HCV in our American Indian and Alaska Native urban communities, specifically in working with elders and youth. We thank you again for taking your time out of your day to join us. Before we get started, I wanted to provide some housekeeping notes of interest. All lines are currently muted. If you wish to ask a question or have comments, please place those in the participant chat pod located at the lower right part of your screen at any time. You can also select the raise your hand icon to have your mics open to speak. There will be a time for Q&A at the end of the presentations. Attendees will also see pop-up poll questions that will be available for you to provide feedback and assist us in gathering additional information from this listening session. Feel free to take those polls at your leisure as they're shown. If you're not speaking, we do ask that you please keep your line muted. You can do so by either selecting the mute function on your phone or selecting *6 if you need to put your phone on hold. We thank you in advance for this. So to get us started today, I would like to introduce Ms. Frances Crevier, who serves as Executive Director of the National Council of Urban Indian Health. Ms. Crevier, who is Algonquin, has been serving Indian Country for more than a decade. She has served in various capacities, from clerking for tribal Supreme Courts and working for the United Nations. Ms. Crevier has a JD from the University of Arizona Law with a certificate in Indigenous Peoples Law. After Ms. Crevier's remarks, we will hear from Julia Dreyer, who will serve as the Federal Relations Director at NCUIH. I'll now turn it on to Ms. Crevier.
Thank you, Kimberly. Hello, everyone, and thank you for joining us today. As Kimberly said, my name is Frances Crevier, and I'm the Executive Director for the National Council of Urban Indian Health. I would like to give a special thank you to all the speakers who have graciously agreed to share their valuable time with us as we discuss the issue of hepatitis C and HIV in urban Indian health. Specifically, I want to thank our partners at the Indian Health Service who will discuss how the agency promotes prevention and treatment activities specific to Indians as a part of their comprehensive public health approach. Principal Deputy Director Riraj Liaki, Acting Director of the Office of Urban Indian Health, Dr. Rose Liaki, and the Coordinator of the agency's National HIV and Hepatitis C program, Rick Haverkate. I want to thank Lindsay, Policy Director for the U.S. Interagency Council on Homelessness, who will shed light on the connection between housing and health and discuss the Council's work to end chronic homelessness. I also want to thank Dr. Colette Adamson, Executive Director of the National Resource Center on Native American Aging, who will discuss the impacts of HIV and Hep C on the elder population. Finally, I want to thank Benjamin Sendecki, member of the National Council of Urban Indian Health Youth Council, who will share the Urban Indian Youth perspective. We are excited to host this event to bring together valued partners and stakeholders who share their best practices, efforts, and to strategize further opportunities to improve the collective impact these deadly viruses have on Indian country. This listening session is the second in a series of Hep C and HIV. On December 10, 2019, we held our first listening session, the focus of which was to provide urban Indian organizations across the United States a platform to express their communities' circumstances, needs, identity gaps, and to share their perspectives and interests with others who are diligently working to support the Eliminating Hep C and HIV in Indian Country initiative. Today's listening session will focus on urban Indian health and youth and elders. NCUIH is a national 501c3 organization devoted to the support and development of quality, accessible, and culturally competent health services for American Indians and Alaska Natives living in urban settings. The NCUIH represents a membership which is comprised of urban Indian health programs funded through Title V of the Indian Healthcare Improvement Act. Currently, there are 41 urban Indian health providers operating in 59 sites. These UIHPs were created by Congress to fulfill the government's federal trust obligation to Indians who live off of reservations. NCUIH members provide health care to the substantial part of the fast-growing Native population which lives in metropolitan and urban areas. More than 78% of Natives now live in urban areas as compared to 45% in 1970 and 8% in 1940. American Indians and Alaska Natives represent about 1.3% of the U.S. population. The 41 urban Indian health programs provide a wide range of culturally competent health care and social services to urban Native communities, including full and limited ambulatory care, dental and oral care, HIV treatment, substance use and disorder treatment, behavioral health, and other preventative services. In February 2019, the current administration announced the Ending the HIV Epidemic, a Plan for America initiative, which is a primary goal to reduce new HIV infections within the United States by 75% in 5 years and by 90% by 2030. The initiative is slated to leverage programs, resources, and infrastructure of HHS agencies and offices, including the Centers for Disease Control and Prevention, Health Resources and Services Administration, the Indian Health Service, National Institutes of Health, Office of HHS Assistant Secretary for Health, and the Substance Abuse and Mental Health Services Administration. Additionally, in March 2019, IHS introduced the Eliminating Hep C and HIV in Indian Country initiative under the administration's A Plan for America initiative. The President's fiscal year 2021 budget proposed $27 million in new investments to expand partnerships between IHS and Native communities to end the HIV epidemic in Indian Country. Survival rates for Native people with HIV and AIDS are lower than any other racial or ethnic group. Additionally, Native peoples who have been diagnosed with HIV and AIDS most often suffer from other related diseases, diabetes, tuberculosis, and hepatitis. Mental health, substance abuse, and addiction complicate primary care-seeking behaviors of Native peoples with HIV. Data has shown that HIV diagnoses have steadily increased in Indian Country over the last 2 years. For example, the 2011-2016 HIV, from 2011 to 2016, HIV infection increased 38% among all American Indians and Alaska Natives. In addition, those communities have seen a 70% rise in new infections among young Native gay men. Across the country, UIHPs provide culturally competent healthcare services and resources that are critical to addressing these healthcare challenges while struggling with constant underfunding. In a recent survey, UIHPs reported that the services they provide are making an impact upon the communities they serve, and although funding is an issue, UIHPs are able to conduct ongoing activities to fight HIV and Hep C while finding opportunities to increase access for Native patients by providing free testing at community events and powwows, becoming a syringe exchange or harm reduction site, treating HIV and Hep C in the primary care setting, becoming an opt-out HIV Hep C clinic, educating, training, and making referrals for physical assistance, offering community-based overdose prevention education, training and enabling staff to openly discuss high-risk situations with patients, provide feedback, and make appropriate referrals. And many UIOs have reported having excellent care coordination relationships with community clinics, Ryan White providers, transportation services, specialists, and other partners focused on HIV and Hep C healthcare. UIHPs have successfully implemented these innovative measures to combat HIV and viral hepatitis for their Native patients. However, American Indians, Alaska Natives are ranked 4 in the nation for new HIV diagnosis despite accounting for only 2% of the population. Additionally, it has been proven that recurring health problems are made more acute for American Indians, Alaska Natives living in urban areas. Urban Indians have greater rates of mortality from chronic disease compared to all other races, and they're also less likely to receive preventative care compared to the non-urban Indian population and less likely to have health insurance. This is why today's conversation is so important. NCUIH is excited to know that IHS has implemented this crucial initiative. However, it is important for our federal partners to truly understand the needs of the programs and the American Indian Alaska Nation patients they have in urban areas. As IHS and CDC apply for additional funding to reduce infections and provide resources, we urge them to consult and engage with UIHPs to ensure that the urban Indian healthcare system is able to provide the same quality of care as the other partners within the IHS ITU system. Again, thank you all so much for coming, and we are very excited to discuss this extremely important topic. I'm now going to hand it off to our 2 wonderful moderators, Dr. Kimberly Fowler and Julia Dreyer.
Thank you, Frances, for the informative opening remarks. Hello, everyone. My name is Julia Dreyer, and I'm the Director of Federal Relations here at NCUIH. We will kick things off first with some updates from the Indian Health Service on HIV and Hepatitis C prevention and treatment. First, we will hear a welcome from Dr. Rose Riaki. Dr. Riaki, a member of the Navajo Nation, serves as Acting Director of the Office of Urban Indian Health Programs at the Indian Health Service. Dr. Riaki joined OUIHP as Deputy Director in September of 2017. He previously served as the Director of Field Operations for the Phoenix Area Indian Health Service, the Director for the Indian Health Service Division of Behavioral Health, and as the Indian Health Service California Area Behavioral Health Consultant. Prior to joining IHS, Dr. Riaki served for 8 years as the Administrative Clinical Director for United American Indian Involvement, an urban Indian organization in Los Angeles. Dr. Riaki?
Thank you, and thank you to NCUIH for providing me with the opportunity to provide a few opening remarks. First, I want to start off just by saying that we know that culturally appropriate health care is a key factor to contributing to the quality of health among urban Indians, and it's also necessary and key to establishing trust and a long-lasting relationship with our patients and their families and our communities. A culturally appropriate health care and addressing social determinants of health are key to impacting positive health outcomes. Our urban Indian organization partners are an integral part of the Indian healthcare system, and they serve as resources to both our urban communities as well as to our tribal members who oftentimes may migrate back and forth from the urban setting to rural or reservation settings, as well as those who come to urban centers looking for education or employment, treatment or specialty care services, as well as a whole other range of services and resources. As Frances indicated, the Indian Health Service has contracts and grants with 41 urban Indian organizations that have 74 locations, provide a range of health care and referral services for urban Indians in 22 states and in 11 IHS regions. Urban Indian organizations have provided over 600,000 healthcare visits for over 75,000 urban Indians across the country. Our urban Indian organizations provide access to culturally appropriate and quality healthcare services that address the whole range of social, cultural, and healthcare needs of the urban Indian communities they serve. So our urban Indian organization partners are an important support to urban Indians who are seeking to maintain their tribal values and cultures in urban settings, and they also serve as an important safety net for our urban Indian patients and their families. Traditional healing and medicine, cultural practices, and an understanding of the historical and cumulative trauma and the healing that's necessary as individuals, families, and communities are at the core of what our urban Indian organization partners provide to our community members. And many of the interventions that our urban Indian organization partners use have been built on protective factors, focusing on strength and resiliency and connection to tribal culture and traditions to help increase engagement and also to have a positive effect on health outcomes. So I want to just say a special thank you to each and every one of our urban Indian organization partners for all that they do for the communities that you serve, as well as to the National Council of Urban Indian Health for not only facilitating this listening session, but also for your partnership with the Indian Health Service in bringing attention to the urban Indian healthcare priorities at a national level. So thank you. I'll turn it back over to our moderators.
Thank you so much, Dr. Riaki. We will now hear from Rick Haverkate, the National HIV/AIDS and Hepatitis C Program Director at IHS. Rick Haverkate is an enrolled member of the Sault Ste. Marie tribe of Chippewa Indians and has been working in the field of HIV/AIDS with American Indian, Alaska Native, and Native Hawaiian Pacific Islander populations for 30 years. His numerous roles have included community health educator, public health advisor, and director of public health at the tribal, state, and national levels.
Great. Well, thank you so much. I really appreciate the opportunity to be here. IHS has worked extensively with the urban programs, and we are very proud of the fact that you are true partners in trying to end HIV and hepatitis C epidemics in Indian country. I want you to think a bit about what it must have been like 30 years ago to get a diagnosis of HIV. I mean, that was truly a death sentence back then. There was very little hope. I think the best people could hope for was to go through the disease with some dignity and pass away in a way that allowed them to be close to their family members, friends, lovers. But we've come such a long way since then. You know, now people who are living with HIV, if they take their antiretroviral therapy as directed, they can live long, normal, healthy, productive lives and have just as long of a lifespan as anyone else in the US population. One other added benefit of that, if a person takes their medications as directed, we can get them to a level of an undetectable viral load. That means they don't have any detectable virus in their body. And that means that that person cannot transmit HIV onto someone else. On top of that, imagine, if you will, someone who was HIV negative 30 years ago, scared of their own shadows, especially if they were part of those groups that may have been sharing needles, may have been men who had sex with other men, and think of the stigma that went along with that, and the fear, the constant fear of not really being able to have a fulfilling life. Now, if those people who are still HIV negative and at risk for HIV infection take one pill a day called PrEP, pre-exposure prophylaxis, that person can be about 99% sure that they will not acquire HIV, the virus that causes AIDS. So those two developments over the last few years, a few decades, have really enabled people to live full lives. And at Indian Health Service and with our tribal programs and our urban programs, we're working really hard to make sure people get that message about treatment as prevention. That means taking medicines if you are living with HIV so that you're untransmittable, and taking PrEP if you're HIV negative. That's called treatment as prevention. Another thing I'd like to remember is something called U equals U. Those two messages really are the heart of what we're trying to do right now. We've been doing health education successfully for many decades. We've reduced people's fear, we've reduced stigma. We definitely have made an impact on getting people to take more precautions like using condoms, but we still see in America in general, not just American Indian population, but in general, we still see about 40,000 new cases of HIV every year, and that it's not been budging. So we know there was something we have to do, and what that something is work really hard in our communities to make sure people hear about antiretroviral therapy and PrEP. We know that about 80% of new infections in the US in 2016, about 80% of the new infections were transmitted by just those 40% of people who didn't know they had HIV or who were not receiving care. So we also have to do a much better job in making sure people hear the message about HIV testing and screening. If we can get 90% of our population screened for HIV, and if we find those people who are living with HIV, if we get 90% of them into care and treatment, and 90% of them who are getting into care and treatment, if we get them to that undetectable viral load, we can eliminate new cases of HIV and get to that goal of a 75% reduction in HIV infection in 5 years and that 90% reduction in 10 years. So there's really, really super good news for us. And I don't think any of us ever thought we'd be at this point. We've done a really great job in IHS screening and primary care for HIV, but we need to make sure we figure out how to get to those people who don't normally come into our care centers. And you know who those are? A lot of times it's our young Native men. I think probably after folks finish high school and they don't really need those annual sports physicals anymore, we kind of stop coming into our urban, tribal, or IHS facilities. We sort of lose them for a while, unless it's emergency care. So we have to figure out how to bring testing to them. Do we do it in mobile vans? Do we do it at community events? Do we set it up in front of or inside of bars and restaurants where we know young men go? But we have to up our game when it comes to testing to get to that level of 90% screening. And in our work in the last few years in IHS tribal and urban centers, we have some communities who are reaching that 90% screening rate. But that's only in those patients who get into the facility. So great job for Indian country, but let's do more and figure out how we can get screening outside of those care facilities. Next slide. And thank you for advancing the slides. I wasn't really looking at my screen. I was just going off my presentation. So I mentioned we have the right tools and the right data. There's great biomedical research that has led to the advancements in drug regimens. We can prevent and care for people living with HIV, and really it's not a miracle. I think it's a lot of hard work, a lot of attention paid to what can be done with science. So let's promote that. Let's talk about PrEP, and we have to really talk about how we reduce the stigma of PrEP. And we have to make sure that people are told about PrEP, that we talk about it on our radio stations and in our newspapers and put posters up in our clinics, and let people know that PrEP is available. PrEP is a life-changing medication treatment, a life-saving medication treatment. So let's not be shy about talking about PrEP. Next slide, please. These are the agencies that are involved in the ending the HIV epidemic. And IHS is a proud member of this sort of elite group of HHS agencies. So IHS was involved at the very start. Admiral Wiyaki was right there, invited to the table. I think oftentimes people think that where's Native country when these decisions are being made at the very top levels of government and of health. And please rest assured that IHS was there at that table in the very early stages of this planning for ending the HIV epidemic. Next slide, please. I want you to look at some of what we call the geographic focus or phase 1 hotspots. You'll see the blue dots around the country. About 50% of all new HIV infections came from just about 48 different jurisdictions in the country. cities and counties, including Washington, D.C., Puerto Rico. So when you think of more than half of the new infections came just from these spots you're seeing on the map. And when they were looking through the data and they saw all these urban hotspots, someone on that planning committee said, yes, but what about high incident rates in rural countries, in rural communities? And a lot of that happens in the South. And you see those states there in blue. Those states have a very high prevalence rates, but low numbers. And we're familiar with that. Of course, aren't we, in Indian country? We know that oftentimes we're overlooked because we have low numbers, but we have high prevalence rates when we look at it per 100,000 population. And you see Oklahoma is one of those highlighted states where we're taking great efforts working with HHS to make sure we bring the message to the whole state of Oklahoma. But I'm sure a lot of you on the phone, since you're working with urban organizations, can find your dot on that map. And please know that we are working closely with NCUIH to make sure we get the message out. NCUIH is a true partner with us. And we're also working with our tribal epidemiology centers, who often include your urban populations in their constituency, or we work closely with the Seattle Indian Health Board, who has an urban tribal epidemiology center. Next slide, please. I want you to know the key strategies of this plan to end the HIV epidemic. There are 4 main pillars. We want to diagnose, treat, prevent, and respond. Diagnose early as possible. Get those folks in for screening. Let them know that they are HIV positive or HIV negative, but do it early. And then treat those people rapidly. I mean, we can get people into same-day treatment. If someone comes into one of our facilities, test positive, we can get them on medication that very same day. Doesn't always happen. I know there are glitches in systems. I know there are reasons why people can't, for a variety of reasons, enter into care, but it really is imperative that we get them into care as quickly as possible. And then we can prevent new transmissions by using interventions, including pre-exposure prophylaxis. But don't forget condoms. Let's never erase condoms from our vocabulary for working with health education to prevent HIV. So we can prevent with condoms and with PrEP. And then we're working with CDC, HRSA, IHS's tribal epidemiology centers to respond quickly to potential outbreaks. Now, and what I think is really important that folks remember, Francis gave some great statistics at the beginning of this webinar, prevalence rates and new diagnosis rates, but please keep this in mind that as we move along in ending the HIV epidemic and we really increase our screening numbers, we're going to see a rise, but that's good news. We have a feeling that we have a fairly large population out there in Indian country who's not been screened but are living with HIV. So as we move into the next couple of years of doing some heavy-duty screening campaigns, we're going to see a slight rise in our new diagnoses. Doesn't mean there's any outbreaks, but we'll look into it. We will keep an eye out to see if they truly are outbreaks or if it's really a matter of just the fact that we're increasing our messaging about screening. Next slide, please. I mentioned briefly about our tribal epidemiology centers. IHS gets a reward each year called the Minority HIV/AIDS Fund. We apply for that. It's competitive. Every year we have to reapply. But this year we decided to apply for some extra funds to see if we could fund our tribal epidemiology centers to look at those 4 pillars of diagnose, treat, prevent, and respond. 2 different groups were funded. Group A are those people who are not serving those phase 1 jurisdictions that you saw on that map, people who don't necessarily include one of those blue dots or blue states. But then we funded another set of tribal epidemiology centers who are serving people in those phase 1 jurisdictions. Next slide, please. Very important. We know it's imperative that IHS listens to our communities. And so we applied for some special funds to do sessions with National Indian Health Board and National Council of Urban Indian Health, what we're doing today. But we're doing a variety of listening sessions, and we funded those 2 organizations to help us out. We think it's imperative to get that voice on the ground, those individuals who are doing that boots on the ground work. So we also sought some funding, and we funded the Albuquerque Area Indian Health Board to put together a group of people from the 12 IHS areas who are really doing either health ed work or medical work or other kinds of face-to-face work in HIV care and treatment and prevention. That's called the National Native HIV Network. So we really are making a strong, strong point to listen to our communities. Next slide, please. Actually, go back one for me, if you don't mind. I just wanted to let you know a little bit about hepatitis C. We talked a lot about HIV, but let me tell you a little about hepatitis C because we're trying really hard to eliminate both. Hepatitis C is extremely prevalent among American Indian and Alaska Native people. AIANs have the highest incident rates of acute hepatitis C infection and the highest mortality rate from all the deaths in the US. Most of them are prevalent, by prevalence. If we look at how many per 100,000, American Indians and Alaskans has the highest death rates related to hepatitis C. And we know that in IHS facilities alone, if you just looked at federally operated IHS facilities, we have about 30,000 patients with an ICD code for hepatitis C, but we think we could have as many as 100,000 American Indian and Alaska Native people around the country who don't necessarily come into an IHS facility. We can only measure those folks who come into IHS facilities. But if we look at tribal and urban and non-native healthcare facilities, we think we have probably more than 100,000 people who would self-identify as American Indian or Alaska Native living with hepatitis C. We treat about 1,000 people per year. We're trying to get better at that. We're working really hard to train our physicians around the country through something called Project ECHO, where we get our clinicians on the phone to share case studies and learn how to treat people. People will come on the phone and say, hey, I have a patient X who's got these kind of complications, and another doc on the phone will say, here's what we did at our clinic, follow this line of treatment. And it's working really, really well. We know that of all the care being done by IHS and tribal folks treating people with hepatitis C, 90% of those people are participating in our Project ECHO. So we're reaching a great amount of people. We're doing good work, but we need to expand those telehealth trainings around the country. So we do have a lot of urban participation. I spoke earlier about our young folks needing to come into care when I was talking about HIV. Hepatitis C in American Indians is a little bit different than the rest of the country. A lot of the country is seeing big case of hepatitis C in their baby boomers, or the little bit older population, our elders. In Indian country, we're seeing a lot of young people with hepatitis C, and we think that has a lot to do with needle sharing. So we're the first in the nation amongst HHS agencies to say universal screening is the way we should go. Most other agencies were saying, let's screen everybody who was born from 1945 to 1965. In IHS, we put out a special general memorandum last year that said, if you're serving Indian people, we recommend that you screen everybody over the age of 18 for hepatitis C. And again, early detection is the key, getting them into treatment, because we can cure hepatitis C. People do not need to live through the devastation of hepatitis C. We can cure it in about 8 to 12 weeks, one pill a day, for around $10,000 to $12,000. Not an impossible task for us to find all those folks living with hepatitis C and cure them. And our clinicians tell us that the main barrier to treatment for hepatitis C is not clinical, it's just the time needed to navigate our folks into the care system. So we're working really hard to make sure that we're getting communities the information they need to promote the idea of hepatitis C, get people in for screening, and get them into care. And with that, I think I'm out of time, and I will wait around for the end of this webinar and take any questions that come. So I really appreciate the time. Thank you to the NCUIH folks.
Thank you so much, Rick, for the comprehensive update. It sounds like IHS is engaged in some critically important activities, and we look forward to partnering with IHS and continuing to work together to address these issues. We will have time for questions and answers and a dialogue following all of our speakers today at the end of this webinar. As part of this listening session, NCUIH circulated a survey among urban Indian organizations to collect more information about the status of and needs for HIV and hepatitis C prevention and treatment services. Dr. Kimberly Fowler and I will now briefly go over some of this information.
Thank you, Julia. So as mentioned, we recently completed a survey of urban Indian organizations regarding the HIV and hepatitis C prevention and treatment services offered and needs identified. Before going into our next speakers, we're happy to report we have closed the survey and have some results to report. The following slides are based on data received from 13 survey recipients.
So for the first slide of results shows some of the priorities. And as you can see, the majority of respondents noted prevention education, health education funding, and education targeting youth was the highest priority to better address HIV, hepatitis C, and co-infection.
Racial misclassification. In addition, racial misclassification and incomplete data create challenges in addressing treatment and prevention among UIOs. Although survival rates for American Indians and Alaska Natives living with HIV and AIDS are lower than they are for any other population, data continues to be a barrier to addressing the epidemic. There's a wide discrepancy in UIO access to American Indian and Alaska Native specific data depending on the geographical location of each program. UIOs may be able to gather data on HIV and HCV patients through a partnership with a state, county, or local health department. However, this data is not usually Native specific, and if it is incredibly outdated. For example, one UIO reported that the most recent AIAN specific data available in their state on HIV and HCV was for 2011. The 8-year-old data showed that the number of American Indians, Alaska Natives diagnosed with the viruses and the Native percentage of the entire affected population was disproportionate. As you can see, only 22% of respondents indicate they monitor HIV and HCV positive patients in-house, with approximately 2/3 indicating they refer patients to external specialists. Although many urban Indian organizations reported having excellent care coordination agreements, when UIOs make needed referrals, patients do not always accept them or follow through. Many UIOs also reported a desire to have their own clinicians trained and to feel comfortable managing HCV as primary care providers in order to remove the extra steps of referring out for specialty care. Other interesting information showed that one issue that came up frequently in the survey results relates to the pervasive stigma around sex and sexually transmitted infections among American Indians and Alaska Natives. As you can see in this chart, these stigmas can have significant impacts on prevention and treatment. UIOs report these stigmas impact their clinics through lack of funding, resistance to treatment, and reveal importance about having conversations regarding these issues. To address these concerns, some UIOs have hired or trained staff who are American Indian and Alaska Natives or added counseling as part of the treatment plans. UIOs report needing sustainable funding, health education, support from medical officials in the community, and support staff training to continue to address these stigmas. With our discussion today, you will see a focus on one of the social determinants of health, housing, as it impacts HIV and HCV prevention and treatment. This chart represents whether UIO respondents address the listed social determinants of health for patients who are positive for HIV or hepatitis C. As you can see, a vast majority of respondents address cultural and traditional health, as well as mental health and substance abuse. More than half of respondents also address psychosocial support needs, injection drug use, healthy food access, financial needs, and housing needs, with just under half reporting addressing sex work.
As you will continue to hear today, funding is a major barrier to adequately addressing HIV and hepatitis C. However, it is important to discuss other needs as well. This slide represents some of the needs UIO respondents identified in addition to funding. Included in responses were data needs, as discussed earlier, prevention education focused on destigmatizing hepatitis C, also discussed earlier, provider education, opportunities for culturally tailored interventions similar to greater health and wellness in Indian country, ensuring programs actually reach and benefit Indian country, safe needle exchange, prevention education in schools, more education for support staff, and bringing culture into the conversation. On the topic of funding, we asked survey respondents to identify the greatest needs for funding. This slide represents a word cloud of responses, with the most common responses represented in larger text. As you can see, the responses were consistent with other answers identifying the need for education and community outreach. UIOs also identified early detection, improved treatment, increased focus on prevention, skilled providers, and culturally tailored programs as areas with which funding could assist in addressing these issues.
The last slide shown here, we want to highlight asked respondents what methods the Office of HIV/AIDS and Infectious Disease Policy could use to promote new and innovative models of prevention and treatment for sexually transmitted infections. Common responses from UIOs included training through webinars geared towards clinician and care teams, continuing using the expedited partner therapy, partnerships with professional organizations engaged in this work, such as AMA and APHA, and targeting at-risk patients in the early stages for prevention, education, and detection.
Several themes were present in the survey results, which we hope to include in our dialogue today after our next presenters, including the need for education surrounding these issues, the need for additional funding directed at addressing these crises in Indian country, the need for better data, working with other agencies and organizations engaged in similar work, and addressing the stigma.
Thank you. I hope you enjoyed hearing about the responses to that survey, and thank you again for your participation. So next we will hear from several presenters who will discuss more specifically the impacts of HIV and hepatitis C on elders and youth. First, we'll have Benjamin Sandecki, who will provide a youth overview and perspective. Mr. Benjamin Sandecki is a third-year PharmD graduate student at Oklahoma State University College of Pharmacy and currently serves as a NCUIH National Youth Council member. Mr. Sandecki also works at the Oklahoma City Indian Clinic, a UIO, where his experience has directly allowed him to appreciate the importance of Native American health and wellness. As a Youth Council member, Benjamin aims to promote healthy lifestyle routines for Native American youth and young adults living in urban settings. Mr. Sandecki's long-term goal is to open his own independent community pharmacy to help support other Native Americans in a culturally sensitive way. Benjamin, are you on the line?
Yes, I am, Dr. Fowler. Can you hear me?
I can, thank you.
Perfect. Thank you very much for that introduction.
If you could share with us a little.
I appreciate it. Yes, absolutely. So it all kind of started, this is a background of the hepatitis C that has affected my family. My father, at the age of 6, he was born in 1968. At the age of 6, he had some flu-like symptoms. It was actually diagnosed as Ray syndrome when they, looked more into it. And at that time, he had a blood transfusion of, I believe it was 99.9 pints of blood. And at that point is when his hepatitis C started. In 2011, there was, a brief, a distant time between his treatment and when he contracted Hep C. But during the treatment in 2011, it was quite the experience to see and, to have him, going through that treatment. And just being exposed to that and having, a loved one who is so near and dear to your family go through something like that was just kind of hard. So just the things that we were faced with as a family was, very challenging. As a child growing up in that time, had to face a lot of adversity, and it just allowed you to be resilient and, fight this so-called like stigma that is very prevalent in the Native population. So it was something that I was able to experience, and then I was granted the opportunity to gain experience at the Oklahoma City Indian Clinic. There we have Hep C clinics that I was able to observe my own patients and kind of follow them along with their treatments. So just the perspective of having a personal history with it direct, correlated with my father, and then being able to, as a healthcare professional, help those individuals who, may be deterred away from treatment because of the stigma that's behind hepatitis C, but just to, help them out, let them know that there is advanced medication now, that is out there for them, and it's okay to get help, and, we're here for them, and, we can ultimately, make them better and, help their Hep C.
Thank you so much for sharing, Benjamin. We appreciate hearing from your perspective how hepatitis C has impacted your life, especially hearing as a child what that meant to your father and his treatment. So thank you for joining us today and sharing that information.
Yes, thank you very much for having me.
So next we will hear from Dr. Colette Adamson regarding elder community support. Dr. Adamson has served as Director of the National Resource Center on Native American Aging at the Center for Rural Health at the University of North Dakota School of Medicine and Health Sciences in Grand Forks, North Dakota since October 2017. Colette received a Bachelor of Arts degree in Economics, a Master of Public Administration with an emphasis in health administration, and a doctorate in educational foundations and research from the University of North Dakota. So with that, I'd like to turn it over to Colette. And Colette, your 2 slides are here if you'd like to move forward.
Thank you, Dr. Fowler. I'd like to just thank NCUIH for inviting me to kind of speak on elder health and social issues today, somewhat related to hepatitis C and HIV. So as Dr. Fowler mentioned, I'm with the National Resource Center on Native American Aging, and one of our missions is to identify health and social issues of Native elders, and primarily we work with Title VI tribal senior service programs throughout the nation. And one of the main projects that we do is we have a Native Elder Needs Assessment that we conduct every 3 years, which we've conducted over a 21-year period with over 300 tribal communities. But what we've found in the information that we've collected with the elder participants is that out of our last cycle, we had over 16,000 elders participate, and over 7,000 of those elders were in urban cluster areas when we use the RUCA code definition, which is Rural Urban Commuting Area Codes. And just to give you a better background of that, it's elders who lived in an area with 50,000 or greater population, and if they commuted to work in that urban area. So when we looked at the rural tribal elders and the ones who fell under this definition of living in urban clusters, we found that a lot of the challenges faced by these elders in terms of health and social issues are very similar. There were some differences, but a lot of the same health and social issues emerged for both groups. So one thing I wanted to start with, just to kind of quickly show you, is here's an infographic that we created looking at the rural Native elders compared to the urban Native elders. And this is kind of focused on healthcare access for both groups. And one that I did want to kind of focus on is barriers to medical care at the bottom. So as we see for urban elders, we see that the top 4 were no transportation, cost, long wait for an appointment, and distance. So whenever we see these barriers to medical care, it does have an effect on presenting challenges for prevention and treatment options for those elders that could be facing health issues such as HIV and hepatitis C for those elders. So we can see that there are some challenges in accessing health care for both urban and rural tribal elders. So I just wanted to give you a quick snapshot of this infographic and some of the results. It has the type of healthcare coverage for both groups, healthcare providers, those that have a personal doctor, and then those that go to a clinic or a doctor's office. And you can see some of the statistical results that we have for that. So moving on, although I just want to put this out here, we don't have data specific to urban elders related to hepatitis C and HIV. And some of the national data, some of it's not available or skewed because some of the groups are lumped together. So it's really hard to identify the rate of hepatitis C and HIV among our Native elders, especially our urban Native elders. But we do know that certain health conditions and social conditions can exacerbate some of the hepatitis C and HIV diagnoses. So for example, people with active hepatitis C are nearly twice as likely to have type 2 diabetes as those who haven't contracted the virus. And then there's also a link between cardiovascular disease and then also neuropsychiatric conditions such as depression and brain fog. So what I wanted to do here was look at this next infographic, which is of Native urban elders from our sample. And as you can see, diabetes is one of the top 3 chronic conditions, followed by arthritis is the next highest, and then high blood pressure is the most prevalent within this population. And then also for cardiovascular disease, it's not on the infographic, but we have urban elders at 8.9% who had identified as being diagnosed with chronic heart disease or congestive heart failure. And then also for depression, we had urban elders that I identified at 13.8% who had been diagnosed with depression. So a lot of these health issues can definitely exacerbate the hepatitis C and HIV conditions that some of the elders do face. Just a few other statistics that I wanted to share with you. You can kind of view the infographic just to kind of see some of the stats, but we see that 29.7% of our urban elders were disabled, and those causes, the top cause included chronic disease at 62.1%, and then accident injury at 27.5%, and then military service and congenital causes. In addition to collecting some of this quantitative data, last summer we did have the opportunity to visit with some of the urban centers who serve Native elders within their sites. And when we spoke to those elders, they shared a lot of their stories and their health issues and their social issues that they face every day. And again, as I stated, we've seen that there was a lot of similarities between urban elders and tribal elders. So, for example, some of the elders had shared with us that they don't have resources to be connected with jobs that they wanted to acquire in where urban settings that they lived. They felt that they didn't have a lot of support to be able to be connected with a job that they would like to work either full-time or part-time, which also can play a role and some of the preventative care that they have access to, or some of the health care that they have access to. So it was really interesting to hear a lot of their stories. But, you know, hopefully we can try to address a lot of these needs with our urban elders by creating partnerships to collect information related to some of their highest priority needs, by connecting them to resources, especially to address hepatitis C and HIV among elders. As I said, there's not a whole lot of data out there specific to our urban elders in the topic area, but I did want to mention that our center is hoping to offer more support to collect this specific data and accurate information on our urban Indian elder populations. So we've been working with NCUIH, NICOA, and other partners on a project called the Native Urban Elder Needs Assessment Survey, which is sponsored by AARP, and we will be collecting data related to hepatitis C and HIV, and that survey will be offered to all urban centers who would like to utilize that at no cost, and then we provide the technical assistance, and that'll be available in the next month or so. So as I mentioned, we're working with NCUIH, so if you're interested in that, please just reach out to us and we can help with that. So I just like to close with, you know, if we just help work together to address these social and health issues, I think that we'll be able to definitely create a better quality of life for our elders overall. Thank you.
Thank you so much, Dr. Adamson. We appreciate you sharing that information. So before we move on to our last presenter, we would like to hear from you all through a quick poll question. So this poll question is asking, are there specific challenges that you see when working with youth or elders that could or does affect reaching elimination status of HIV or hepatitis C? Please feel free to respond by typing your answer into the poll window, and we'd be happy to share this information with everyone on the line as well as with Indian Health Service. Are there specific challenges that you see when working with youth or elders that could or does affect reaching elimination status of HIV and HCV? Yes, stigma is definitely a large one that we see. Really trying to overcome stigma in order to make sure that someone even accesses care. Are there other challenges that anyone in attendance can think of? Okay, so I think stigma is definitely a really big one. Oh, thank you. For elders, how do you explain the concept of HIV or HCV? Very important point. I think that Dr. Adamson would also agree with this in trying to think about elders that may have dementia or that really aren't able to cognitively understand the concept. So that's definitely, those two are definitely really great responses. Okay, so we'll close out that poll and we'll continue moving on. Thank you all for your participation. So I'm sorry, I'll turn it over to Julia.
Thank you so much, Dr. Fowler. And thank you everyone for your participation. Next we will hear from our last presenter, Lindsay Knott, Policy Director for the U.S. Interagency Council on Homelessness. Lindsay leads the Council's work to end chronic homelessness and homelessness among single adults. For more than a decade, she has worked to improve housing stability and to prevent and end homelessness both nationally and at the local level. Lindsay previously led a variety of projects for the West Virginia Coalition to End Homelessness, including the statewide point-in-time count, the SSI Outreach, Access and Recovery, or SOAR efforts, and Continuum of Care project monitoring. Lindsay holds a Master of Social Work degree from West Virginia University.
Great. Thank you, Julia. Can you hear me?
Yes, we can hear you perfectly.
Fantastic. As Julia mentioned, my name is Lindsay Knott. I'm Policy Director with the U.S. Interagency Council on Homelessness, and I want to thank NCUIH for the opportunity to be a part of this discussion and to all of you who are doing work on the ground and across the country to address these issues. I started my career as a social worker in a hospital program, working to make sure that people living with HIV or AIDS had access to stable housing and care. I am not a healthcare expert, but I do work at the center of housing and health to ensure that all people have the stability of housing that allows them to meet their health and other goals, including natives living with HIV and Hep C and other people with disabilities. So just a little bit of background on who USICH is. We are a federal independent agency that's charged with coordinating the federal response to homelessness. We're also focused on coordinating and creating national partnerships at all levels of government and with the private sector and nonprofits across the country. And our goal is to really maximize the federal government's response by ensuring that resources are being used in an effective way to address the needs of people experiencing homelessness. This slide just gives you a sense of all of the federal agencies who are part of the council. There are 19 of them. So we have a large convening role, and this is an important body of federal agencies who are being brought together to focus on all of the issues that impact people experiencing homelessness or housing instability across the country. Back in 2019, USICH developed and released a new federal strategic plan to end homelessness called Home Together. The plan really focuses on ensuring that home is the center of everything that we're doing, and that we're striving toward this together, because we know that the solutions to homelessness and housing instability are multifaceted, and they require all of us being at the table. And that includes our partnerships with tribes and urban native communities and other experts, which I'll go into in a couple of minutes. But these partnerships are critical to this work. There are a number of goals that are articulated in the federal strategic plan: ending veteran homelessness, ending family homelessness, ending homelessness among youth and young adults, ending homelessness for other individuals, and ending chronic homelessness among people with disabilities. So our work in this area is focused on supporting communities to integrate housing and health and behavioral health care services to address the needs of people experiencing or at risk of experiencing chronic homelessness. And when we say chronic homelessness, we mean long-term homelessness among people with disabilities. Our work at the Council also focuses on other subpopulations of people, including the elderly, as well as American Indians and Alaskan Natives. So simply put, the solution to homelessness is housing and support. And that support is about what people need and choose. This often includes necessary health and behavioral health care, substance use treatment, aging services, educational and career opportunities, and child care. So it's really about pairing the two. And what's important is that housing be accessible as a platform for layering on those services and supports. Numerous studies have shown the effectiveness of this approach. And we talked a little bit earlier in the presentation and the discussion about the social determinants of health, and housing is one of these, which we saw on that chart, which showed up in the survey. So for this reason, there's a lot of momentum behind housing as a social determinant of health and about the connection between housing and health. And on this slide, here's just a snapshot of what we know. This is certainly not comprehensive, but effective implementation of permanent housing reduces returns to homelessness. There are evaluations of supportive housing programs using a housing first approach that show housing retention rates between 75 and 85% for single adults and between 80 and 90% for families. Housing improves other outcomes. From a study in Chicago, we saw that people who were receiving supportive housing as compared to who were coming out of hospitals saw 29% fewer hospitalizations, 24% fewer emergency room visits, and 24% fewer days in nursing homes. And we also know that housing offsets costs and improves savings for the healthcare system. So there truly is such a strong relationship between these two, and there is strong data to show that when permanent housing is being effectively implemented, using housing first approaches that don't require preconditions to housing like sobriety or service participation, that people are really successful and that their health improves. And this includes people living with HIV. So again, access to stable housing improves health outcomes. We know that not only is homelessness a strong predictor of poor health, but that it complicates the provision of care of HIV and hepatitis C. And I saw this firsthand when I was working with people living with HIV and AIDS, and this is something that is certainly an area of focus for the council and for our partner agencies, HHS included, who of course is really strongly represented on this discussion. So the same study that I noted on the last slide from Chicago assessed the health impact of housing and case management programs for people living with HIV, and they found that housing interventions improved the health of HIV-positive people experiencing homelessness. So having access to stable housing did, in fact, improve the health of people who were HIV positive. So I want to shift briefly to our focus on ending homelessness and housing instability among American Indians and Alaska Natives, which also includes a strong focus on these health and housing partnerships. The council over the last 5 years has really invested more time and energy in understanding the particular housing needs of tribes and urban Native communities, and to partnering with tribes and urban Native communities to ensure that housing and services could be accessed so that those communities could end homelessness for this population. In 2016, we developed an interagency working group with a number of different federal agencies at the table that is focused on a number of different topic areas. The first being improving access to housing and services through all of the different tools that are available at the federal level. We're also focused on improving data collection to better enumerate the size and scope of homelessness and housing instability among American Indians and Alaska Natives, because we don't have great data on this issue, particularly when it comes to housing. Ensuring that all of the things that we're doing are being informed by consultation and engagement with tribal leaders, urban Native communities, and other experts, and elevating the awareness of the crisis of homelessness and housing instability. And of course, all of these issues are impacted by the health needs of people, their disabling conditions, their access to health and behavioral health care. And so we have strong participation from our health and human services federal partners at this table to ensure that we are doing what we need to do at the federal level to better blend and braid these resources to make sure that they're available to communities and to support communities to scale interventions that support the long-term health and housing of people. Consultation, again, has been a really big area of our focus. On this slide, it's just a couple of pictures of a couple of different consultations that we've been able to participate in, one including some travel we did to Sazunga, Alaska, which is in the Bering Strait, closer to Russia than it is to the United States. And there we were able to see firsthand the impact of the lack of safe housing on people's health and other outcomes. And then I wanted to highlight quickly some technical assistance that's being delivered by the U.S. Department of Housing and Urban Development in partnership with other federal agencies. It really focused on improving partnerships at the federal, state, and local government level, and with tribes and urban Native communities to ensure that housing and services are being integrated in those communities and that there's support to do that. And as a part of this, there is a focus particularly on scaling permanent supportive housing interventions that are really well equipped to deal or to respond to the needs of people who are experiencing homelessness with disabilities, either on tribal lands or off of tribal lands. And as a result of this effort, there are a number of new permanent supportive housing projects that are being developed by urban Native organizations, and we know tribes are looking at this too, in an effort to ensure that people have access to the housing that they need. Okay, and on this slide, and I hear a little bit of background noise, I'm not sure if that's intended to be directed at me or not, but I wanted to provide my contact information, and with that, I'll turn it back over.
Hi, can everyone please make sure to mute your line if you're not speaking, please?
Thank you. This is Becky Morgan at NCUIH, National Indian Council Region. The phone number is 505-292-2001. Okay, thanks. Bye-bye.
Well, thank you so much, Lindsay, for the informative presentation on housing as a co-occurring issue and how chronic homelessness can impact health status, as well as some of the types of initiatives that can improve health outcomes. And thank you to all of our presenters and participants for sharing with us this critical information this afternoon. Next, we want to open up the discussion to include our speakers, as well as attendees, with a Q&A and dialogue. As mentioned earlier, attendees have the ability to write into the chat pod with comments and questions at any time. If you would like to speak, please select the raise your hand feature to have your mic open. Attendees will also see pop-up poll questions that will be available for you to provide feedback and assist us.
We're just trying to get
Hi, I'm sorry. If you're not speaking, could you please mute your line? So you will also see some poll questions that will give you an opportunity to provide feedback and assist NCUIH in gathering additional information from this listening session. Please feel free to take those polls at your leisure, and if any folks want to ask any questions, please do so through unmuting your line or using the raise your hand feature, as well as the chat pod that is available.
You're talking about like physical activity training? Well, the best person would be to talk to Cece Acosta. For the Senior Olympics here in New Mexico. Susan Roswell, and looks like, hello, if you're on the phone currently, if you could please mute your line, we would appreciate it. 5777. If you're talking on the phone, I'm sorry. And it's Cecilia Acosta, Executive Director, New Mexico Senior Olympics. And I think it's from someone from NCUIH. If you're able to mute your line, we would appreciate it. Okay, to start off our discussion, we'd like to start with a poll question. This poll question, number 3, is really trying to find out more information on support needed. Is it a way to mute all lines? That's a location and that's a date. I don't have a time. Okay, so Dallas is 1 p.m. 1 to 3. Okay. That's how we need it. Okay, great. Thank you. Thank you. To whoever is we're both getting on the phone. Have a good day. And then we are happy always to get this information out to the people in New Mexico. So just let us know. Okay. Morgan, Becky Morgan.
The leader has muted your line. To unmute your line, press *6.
Okay, so let's try this again with our polls. Yeah, thank you so much for muting the line. So we'll start with our next poll question, which is actually on the screen already. It's asking, do you feel that IHS has provided urban Indian organizations or your organization with the support needed to assist in reaching the HIV/HCV elimination initiative? And this is a straightforward yes or no or somewhat response that you could select from. We'd be appreciative if you could take our poll. And also, while you're taking this poll, if you have any additional comments or questions, feel free to write them into the chat pod. You can also use the raise your hand feature. We can open up your mic so that you could also speak and respond. Thank you all for taking the poll. While we're queuing up, I'd like to ask Andrew if there's any comments in the chat pod that we need to respond to as well.
Hi, Dr. Feller. 2 questions that were asked earlier during presentations. The first one was, how can we find out more information about the survey that Dr. Adamson mentioned?
Colette, if you're still on the line and are able to respond, we'd love to hear from you. Oh, press *6 if you're unable to speak. I'm sorry.
Hello?
Yes, we can hear you.
Okay. You can contact me directly at my office phone is 701-777-0676, or my email is just colette.adamson@und.edu, or you can also reach out to Alejandro or Kimberly. Is that okay, Kimberly? For more information as well.
Thank you, Colette.
You're welcome.
Thank you. And one other question that came through the chat earlier, asked if the treatment regimen was different between young patients and elders, and I did see that Rick did provide a response to that. Rick, if you're still on the line, would you like to provide a response so that other folks who might just be listening in can hear?
Sure. Can you hear me?
Yes, we can.
Okay, hi. Yeah, this is Rick Havergate from IHS. There are a lot of differences. There are quite a few similarities in an HIV treatment plan. No matter the age, there are some really specific antiretroviral therapies. But we have to take into consideration always the individual needs of each patient. So as a person ages, we all need a variety of different kinds of care than we needed perhaps when we were 25. You know, our kidneys change function, our bones get more brittle, maybe our cognitive abilities change, our cardiovascular systems change. So we do definitely take all that into account. Now, we do have an Indian country echo. I spoke of echo early in my presentation, where we get providers from around Indian country, including urbans, together to discuss special patient needs. And I just checked with those folks, and they have not yet had any specific sessions dealing with our elders and HIV care, but we think it's an important idea. So thanks, Larry Curley, for putting that out there, and we'll start a didactic around that in one of our upcoming echoes, and hopefully we'll be able to report back to this group or maybe individuals in the coming months and how that's going, what kind of topics are coming up, and what kind of care plans are being developed for Indian country and for our elders. But great question, thank you.
Thank you so much, Rick. Do we have any other questions or points of discussion? And as a reminder, if you'd like to speak, please push *6 to unmute. Okay, well, in the meantime, while we wait for some more questions, we did put up a 4th poll. So this one asks, what supports from Indian Health Service does you need to assist elders and youth in reaching the goal of elimination of HIV or hepatitis C? Thank you, and we are getting some answers. Information for Indian country and urban areas to use in clinics, as well as stigma reducing campaigns. And while we wait to see if any more answers come, oh, sorry, go ahead. Hi, this is Sunny Stevenson with NCUIH, and I had a question for Lindsay Knott from USICH. How can UIOs learn more about USICH's work and opportunities that they can take advantage of?
And Lindsay, if you need to press *6, that may unmute you. Hey, this is Lindsay. Can you hear me? Yes, we can.
Perfect. Great question. So our work, you can find more information at usich.gov. It'll provide an overview of the council, of the different population areas, the different solutions that we're promoting, including permanent supportive housing, and other permanent housing interventions. I provided my email address on the slide, or in the set of slides. I would be happy to connect individually to point to particular communities that are doing good work, if that's helpful. And I think that we could get to some specificity about exactly what types of models folks are looking for, but I'm happy to be a resource offline via email to point to those communities that I think would be willing to share all of their good work that they're doing.
Great, thank you.
So we had a few other responses that came in response to the poll question. It looks like education and testing, stigma reducing campaigns are all areas, and support for coordination of care are all responses that came in for IHS to support elders and youth. I think the topic of information and resource information to share at urban clinics is an important one, and I don't know, Rick, if there's any materials that have been created at this point for that.
I can't say that there are any specific materials for elders on those issues, but it's definitely something we can look into, and I appreciate the fact that people are so interested. I'll look forward to getting a copy of these questions so I can work directly with people's concerns from today.
Okay, thank you so much.
Hi, so in the survey, I saw that UIOs had identified partnerships with other organizations as a priority to address some of these crises. What are some of the best practices or any strategies that have worked to effectively form and utilize some of these like-minded partnerships?
This is Kimberly. I can start answering that question, and Julia, if you want to add on to it, feel free. So as far as partnerships for urban clinics, definitely look in your local area. If there are other organizations that are specifically working in the realm of HIV and hepatitis C, those may be great partners to reach out to, especially if there may be someone in your community that's native that may not have connected with your urban center. They may have connected with just one of the local programs after they determine a diagnosis, or even trying to prevent or access care. That may be a good use of building those partnerships. I would also say that being able to utilize those partnerships to even go after opportunities for funding could be another resource to utilize too as well. Having a larger organization or another organization as if there's a coalition or a collaboration that could be created, maybe an opportunity too as well if the actual funding source isn't specifically for American Indians and Alaska Natives, but maybe having some type of carve out that you would support under that partnership. I don't know, Julie, if there's any others that you can think of.
Yeah, I think one other thing I would suggest is to look for events occurring around these issues as a good way to connect with some other folks in the space. So, for example, keeping an eye out for different webinars, even doing newsletter and events, email lists from organizations that you know are engaged in this type of work, and some other ideas like that to sort of get in touch with the right folks who can help form some of these partnerships. Does anyone else on the line from a different organization or from an urban Indian organization or any of the other organizations that are on that are partners with UIOs have some suggestions as well? And as a reminder, please dial *6 to unmute your line.
We have a few people typing in, and even if our presenters, if you have any best practices for building partnerships or building capacity to address these issues, if you'd like to share any of those. Or it might be a comment under, but I think that looking for come from federal or private sector that may help in those partnerships. Looks like that may also be a suggestion or option.
So
I think also when it,
so just restating that, I believe you were reading the question from the chat.
yes.
The question is, are there any federal or private sector incentives that support urban programs in building these partnerships?
This is Kimberly. I'd like to also I like to offer the suggestion of if you live near a university campus, that may also be another partnership that you could look into, especially when you look at the area of working with youth and young adults. So they may either have some type of Native student support, or even researchers there that are working on these topics that might be helpful to present to your community, especially for educational resources.
And as a reminder, if anyone else wants to chime in on this, including any of our presenters, we did have to mute all the lines due to some background noise. So you will need to dial *6 before other folks will be able to hear you. And while we're waiting for the next question, we can pull up another poll. This is Sunny Stevenson from NCUIH. Sorry. Go ahead, Sunny. I apologize. Oh, I'm sorry. I wasn't sure if you could hear me. I have a question for IHS, IHS staff. Is there any talk right now about moving the HIV or Hep C funding under the U.S. Department of Health and Human Services to 638 funding? And if so, how will IHS ensure the HIV and Hep C funding is available for UIOs?
Hi, this is Rick from IHS. I am the coordinator for the National HIV Program. However, I don't have a lot of know-how on how the funds are determined. I can tell you that IHS gets a base award of around $400,000 each year to work with HIV. 100% of that money goes out to 638 tribal shares. So I keep zero of that money at headquarters. It all goes out to tribal shares. And I don't know that there's any special funding from IHS directly to 638 tribes. Those are things you'd probably have to work out with your tribes and your advocacy groups. IHS always does whatever we can to make sure funds get to the tribal and urban locations. For example, each year I do apply for competitive funds that come from the Minority HIV/AIDS Fund. Only a certain amount of HHS agencies like IHS are eligible for those funds, but I apply. Last year we got about $7.9 million, and 100% of those dollars went out to tribal and urban facilities around the country, but we have to give those funds and target that programming to those areas with the greatest need. And a lot of the greatest need around HIV is in the U.S. Southwest. A lot of the greatest need in Indian country for hepatitis C is in the upper plains and Great Lakes area. We do make sure that we are looking at treatment and care options, support options in those areas with the greatest need, but we have a lot of national reaching programs like our Project ECHO that trains providers from all over the country working with American Indian Alaska Native patients on how to best treat HIV and hepatitis C. And then we also fund programs that are web-based or using social media to reduce stigma, to educate teens, to educate other folks around HIV and hepatitis C. So we do a lot of work, but I can guarantee that IHS always advocates to make sure the funds get to tribes and urbans. We do some of it ourselves directly. When we're not doing it directly, we always tell people we need to get this to the community level, and we do the same thing. So that's the best answer I can give you. I hope it didn't seem like a runaround, but I can tell you IHS has zero funds that stay in-house. In fact, I don't have a budget. I don't have a budget for a piece of paper or travel. It all goes out to 638 and whenever I can to urban Indian organizations.
Thank you, Rick. And as far as the responses to our poll are concerned, it looks like 100% of you all are actually in-house providing access to care for monitoring HIV positive and hepatitis C positive patients. So that's really helpful to understand and know, and glad that you all are able to do so. I think we may have one more poll if we don't have any other comments, direct comments. This is an open-ended poll, and it's just asking, how can federal agencies better partner with states to more effectively support urban Indian organizations' efforts to address HIV and hepatitis C when it comes to youth and elders? So understanding if there's partnerships that need to be built specifically around youth and elders, for support of UIOs. Feel free to type into the chat window and place your responses there. We'd be really excited to see those. Thank you. We've had one response come through that is actually giving the suggestion of creating funding opportunities, I'm assuming directly for states and tribes. Also listed is providing more funding and technical assistance to UIOs to further tackle HIV and Hep C in these populations. Both very good responses, and thank you for responding. Definitely the idea of having more resources to help in this, tackle this issue, these issues, is important. Thank you. So also marketing materials, having marketing materials about PrEP focused on American Indians and Alaska Natives. So if there are current materials, tailoring those to Native communities.
Hi, this is Andrew from NCUIH. I was just curious because we've heard a lot about stigma presenting a challenge for both HIV and Hep C. And I was curious, what are some strategies that either youth or elders have used in the past to combat stigma, either on this or any topic, really?
Thank you, Andrew. Would anyone on the line like to respond to that? You can feel free to write into the participant chat. If there's any ways that you or that you know of that have assisted youth and elders in overcoming stigma. Any activities, any initiatives?
And as a reminder, if you're trying to speak on the line, you just need to dial *6 to unmute.
And I think this is relevant, but someone typed in that we should have culturally and linguistically appropriate materials created. That's definitely important in making sure that those materials are reflective of the communities that they're going to be placed in. Does anyone on the line have any initiatives that they have currently in place to assist elders or youth in your community in educating them about HIV or hepatitis C, or getting them tested, any of those types of initiatives that could definitely help to overcome stigma?
Well, thank you everyone so much for attending. And if you do have any questions remaining, feel free to reach out to a member of the NCUIH team or any of the presenters. Thank you so much for joining us today, and we truly appreciate the wonderful information provided both by presenters and through the polls and discussion and dialogue that we just had. All the event information, including the recording and slide deck from this listening session, will be located on the NCUIH website at www.ncuih.org and through our newsletter as soon as they are available. Lastly, we ask that you take a few moments to provide feedback on today's listening session through the evaluation survey that will display at the close of the session, or through the SurveyMonkey link that is now located in the chat pod. As always, please feel free to contact us if you have any additional comments or questions. You can email myself, Julia Dreyer, at jdreyer, D-R-E-Y-E-R, @ncuih.org. And I will be happy to pass those on to speakers or answer as appropriate.
Thank you again, everyone.